Good afternoon, and welcome to our webinar, Navigating the Pandemic, Unveiling the Impact of Non-Pharmaceutical Interventions and Vaccines. This webinar today is brought to you by the Institute for Pandemics, IFP, housed at the Dalla Lana School of Public Health at the University of Toronto. My name is Nelson Lee, Director of IFP, which is an institutional strategic initiative of U of T. Currently, we have more than 180 faculty members across 11 academic divisions joining us with goals to power interdisciplinary research and training so that we can better prepare for and respond to pandemics and future public health emergencies caused by communicable diseases. Before we begin, I would like to acknowledge this land on which the University of Toronto operates. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still the home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. A couple of housekeeping items. Please use the Q&A feature to ask any questions. Given the limited length of time, please kindly understand that we may not be able to get to every question asked. The webinar is being recorded, which will be made available on our IFP website at a later date. The webinar will now begin. First, I would like to introduce our presenter for today, Professor Paul Grootendorst. Paul is an associate professor in the Leslie Dann Faculty of Pharmacy. His research addresses important economic issues in the pharmaceutical sector, as well as health services and public policies, including vaccine development, regulation, delivery, and real-world outcomes. He's going to share with us data on vaccines and non-pharmaceutical interventions impact on health outcomes during the COVID-19 pandemic. This presentation will then be followed by a panel discussion. We're excited to have 3 panelists, all from different disciplines and institutes, joining us today. The first one is Dr. Mehdi Ammi, who is an associate professor in the School of Public Policy and Administration at Carleton University in Ottawa. His research is on health economics, health policies, and pandemic interventions on health economics outcomes. The second is Dr. Sharifa Nasreen, an assistant professor in the Department of Epidemiology and Biostatistics in the School of Public Health at Sunny Downstate Health Sciences University, USA. She's formerly with Dalla Lana. Her research focuses on public health and epidemiology, especially on vaccine-preventable diseases. Alexander Meek is a PhD candidate in economics at the University of Guelph. His research focuses on the interaction between public policy and health and NPIs during the pandemic. So now I'm going to turn over to Paul to give his presentation. Thanks, Paul.
Thank you. I'm just going to turn off the video since my internet's a little bit wonky. So welcome, everybody. Can you believe it? It's been 4 years since the start of the COVID pandemic. How time flies. And enough time has elapsed to compare Canada's provinces in their COVID containment policies and the resulting impacts on mortality and economic activity. And that's what I do using publicly available data from Stats Canada, PHAC, Oxford, Stringency Index. Before you get too excited, this is a purely descriptive exercise, although Alex and Mehdi have done some causal impact analyses. So first of all, as we believe, SARS-CoV-2 originated outside of Canada. How did the border controls in each province affect the number of international arrivals into each province? Well, we see large declines in Ontario, BC, and Quebec. But the pandemic arrivals into Ontario are still greater than pre-pandemic arrivals in most other provinces. So if you look at the during the pandemic, a lot of people from overseas or outside of Canada were still entering Ontario, and that's a potential source of a conduit of the SARS-CoV-2 virus. We can also look at the number of people entering each province from both overseas or outside of Canada and domestically from other provinces. And this is what you see in this graph. So we see arrivals in each province increased. There was obviously a decrease during the COVID era with the border controls in place. But the arrivals quickly increased in mid-2021, roughly 1 year after the start of the pandemic, and plateaued a bit and then increased again in early 2022. So that tells you about the influx of potential COVID cases into Canada's provinces. Obviously, the provinces responded by instituting various non-pharmaceutical interventions, various social distancing control policies, which are captured in this thing called the stringency index, which has been Canadianized by a group in Ottawa. I actually forget the name of the group that did the province level translation of what is otherwise a national stringency index. I believe it was the IRPP. In fact, it was Montreal, not Ottawa. So what I have in blue is the province level stringency index, and I understand that other people have used different indices. And I show how this evolves over time. This is a weekly average of the index by province, spanning the start of the pandemic to the end of 2022, which is when the index was stopped, when the index was no longer recorded. That's the blue line. The red line is the number of new COVID cases per 100,000. This is reported to the provincial public health authority. Okay, so what do we see here? Well, what struck me about this graph is that the Atlantic region had very low COVID caseloads until the restrictions were eased in early 2022, at which point they shot up like a jackrabbit. PEI, for instance, right after the restrictions were eased, had 2,000, in 1 week, had 2,000 cases per 100,000 population. So 2% of the population in that week was infected or was deemed to have been infected by the COVID SARS-CoV-2 virus. Moving on to Alberta and Saskatchewan, what struck me about these two provinces is the large fluctuations in caseload from the fall of 2000 onwards. You see how much they fluctuate, right? It seems the fluctuations were a little bit higher than in the other provinces. And recall that BC and Ontario, from our earlier international arrivals graph, had the largest numbers of people arriving from overseas or outside of Canada. And they seem to have, and Quebec is, I guess, would be in third place, they seem to manage their caseload pretty well despite the large international arrivals at the earlier, like at the months preceding the pandemic when the virus was circulating and during the pandemic era. They seem to do okay in the first few months of the pandemic. Let's now drill down into the nature of the kind of social restrictions, social distancing restrictions that each province instituted. The index, the overall index, is a sum of a bunch of sub-indices. What I did is I identified values or weeks during which the sub-indices were particularly stringent. So, for instance, the gray shaded area indicates the weeks during which gatherings were restricted to be 10 people or fewer in each province, right? So you can see, for instance, BC had that policy in effect Well, it started actually around the time of the pandemic. It was eased slightly, roughly in the fall of 2000, and it was reinstituted. The orange with the dash border indicates periods during which all schools were closed. The green with a long dash border indicates a provincial policy of closing or work from home for all but essential workplaces. So most businesses, except for instance, grocery stores and physician offices were closed down. Pretty stringent policy. And then the most stringent policy, I'd say, would be the blue with the solid border, which is the stay-at-home order. So you were required to stay home except for things like grocery shopping and essential trips, right? So those are that's the kind of the nuclear option, I'd say, in terms of the public health arsenal to reduce social interactions and hence mitigate the spread of the SARS-CoV-2 virus. So if you look at these graphs, which shows you the provincial level restrictions on each of these dimensions, you'll see that the Atlantic, again, I didn't show this, but they had a kind of a regional travel bubble. They had a strictly controlled entry from outsiders, or as they say in Newfoundland, come from a ways, into their region. And they also enforced, I think, within between province controls as well. I know that the travel into the area was so low that WestJet started to cancel flights. Anyways, if you notice that these provinces, what they did is they were able to control the infection rates using these border controls, and then they would, whenever they had a flare up in cases, they would have a very short-lived restriction of some form. For instance, New Brunswick, there was brief stay-at-home orders. You'll also notice that the second thing I graph on this graph is the number of new COVID deaths per 100,000. That's in the purple line. You'll see that has spiked up in some provinces. We'll talk about that in a second. We'll talk about it now, actually, for PEI. Pete, you see in these provinces, a lot of the mortality, COVID attributable mortality, occurring right after the end of these kind of most stringent restrictions. So PEI experienced almost all of its mortality after the start of 2022. New Brunswick had massive increases near the end of 2022. Okay. Ontario, Quebec, two major destinations for people who arrived from outside of Canada at the start of the pandemic. They experienced the largest increases in first wave COVID mortality, as you can see here. The spike in Quebec was particularly pronounced. And that, I think, emboldened policymakers, public health authorities in those provinces to be more aggressive in their control of infection using these NPIs through the remainder of the pandemic. So Ontario made liberal use of the stay-at-home orders, as did Quebec, for instance. They almost had, I guess they had to, because like I said, these were the initial caseload, well, the initial number of people potentially infected could have been higher by virtue of the number of international arrivals. That's my take on it anyways. BC, I think, did very well throughout the pandemic. I'm just gonna, I think the jittering on my internet browser signal has stopped. I'll see if I can put the video back on. What we see in BC actually is a very good performance overall. Again, these were the second most common destination for international arrivals. They managed the COVID caseload quite well. Despite that, they kind of seem to hit the magic sweet spot, I think, in terms of balancing the onerous aspect of these social distancing restrictions with the need to control the pandemic. Okay. Now, if you move over to right. If you move over to Alberta and Saskatchewan, I think Alex and Mehdi may have capitalized this in their empirical work is that we see, especially in Saskatchewan, relatively high rates of COVID mortality, COVID attributable mortality without a corresponding policy response. Yeah. We don't see any of these particularly onerous restrictions in place after the summer of 2021. So yeah, they seem to be most hesitant to lay down the law to imply these MPIs, despite large mortality surges. Mehdi, as-tu une question?
Just, c'est pas une question. Just to add to your point on Alberta, I think was really striking to see that the death rate was much higher than in Ontario, despite Ontario, being a much bigger province, much more travel, as you mentioned earlier. So I think that was also another striking result. And because I'm struggling to see well the scale in Saskatchewan, but it seems it's also even higher in Saskatchewan. So we looked more into Alberta, to look into Saskatchewan independently, but I think that was a striking descriptive finding, what you mentioned right now. So thanks for that.
Okay, thank you for the vote of confidence. Yes.
And perhaps the question I had was more in Manitoba, where you have like this very heavy-handed, policy period, the blue window. Is the blue window including as well the school being closed, or that's where I was not sure actually?
Well, if memory serves, school closures are orange. Let me see if I can go back to the. Yes.
Okay.
Orange with dash border.
Okay.
Yeah,
blue
no, actually that was business closure. I don't know if they closed schools in
the blue. Okay.
In Manitoba.
Okay.
Now, mind you, the index that I'm using could be wrong, right?
Thanks.
Okay. Okay, so where was I here? Alberta, Saskatchewan. Again, their policy approach was a bit less. They were less likely to use particularly stringent policies in those provinces. All right. So another way of mitigating the virus, as you know, is to vaccinate people. And here I've grabbed some data from our friends at PHAC, Public Health Agency of Canada, and we've got the fraction of the population in each province by sex, male and female, that completed their primary vaccination series, which for most vaccines was a 2-shot series. And females, being more responsible, had higher uptake than males. Females are red, males are blue. That's true in every province. Alberta, Saskatchewan, lowest uptake of all the provinces, and uptake rates tend to be a little higher in the Atlantic, like Newfoundland had the highest rates of the primary COVID vaccine uptake. Here's a bit more noisy graph, again, PHAC data, showing the uptake rates not by gender, but by age group. Green being 18 to 29, blue being 40 to 49, purple being 60 to 69, and red being 80 plus. It's a bit noisy because what happens is the denominator, I think, are based on annual estimates. So the population, the population that you're dividing by to get the fraction uptake is a bit noisy. That causes a little blips in the data. But regard that being aside, the uptake rates increase of age, no question about that. Here's the data from PHAC again. It's the booster vaccination rate. The people who obtained a first and second booster. The top one is the first booster, and the bottom one, the blue booster, the second booster. The red again is females, blue again is males. And again, we see differential by sex, females are less vaccine hesitant, and then also by region. Again, Alberta, Saskatchewan, particularly low rates of booster vaccine uptake, and our friends in Newfoundland, particularly high rates. Overall, though, the booster uptake is much lower than for the primary series. I think primary was around 80%. Eventually, these are nationally, the first booster was roughly 50%, and the second one was like 25% uptake.
And
So
Paul,
what happened to
sorry, I wanted to ask about Quebec. What's happening with this series for data in Quebec? Because it's just like very short. Do you know what's happening?
I'm not exactly sure, Mehdi. I think the public health agency that operates in Quebec did not share their data with the federal agency.
Yeah, thank you.
I couldn't detect it anywhere on their website. It was simply missing. I believe there's some PHAC folks on this call who might be able to assist or provide a different explanation. It could also be data quality. Perhaps that's another reason it may have been unavailable. So let's take a look now at. So we looked at sort of the initial level of potential infection by virtue of international travel. We've also looked at provincial policies in respect of NPIs, these stringency measures. We looked at vaccination. Those two things, like the three things, the initial flow of potentially infected people into the province, the NPIs, vaccination, and combined with compliance. Obviously, you can have a law in place, but people could not comply with the laws. Those four things, to my mind, affect the outcomes we're going to look at now. Economic outcomes and mortality outcomes. So here's the economic outcomes. Economics actually is a bit more complicated because what happened, of course, during the COVID era was a massive drop in the price of crude oil, which adversely affected Alberta's fortunes, didn't it? So there's a bunch of things happening here in Alberta, causing their real per capita GDP to decline. These data extend from 2000 to 2022, or Stats Canada data. I'm also struck by the differences across provinces. This is a side note. I was never actually aware of this variation, but if you compare the top and bottom provinces in terms of their real per capita GDP, at baseline, it's almost double. Like you look at PEI compared to Alberta, right? It's it's almost twice as high in Alberta as it is in PEI. Anyways, that's a side note. It appears that the impact of the COVID now, and of course it depends on, there's global factors like oil prices that play here too, but look at Manitoba's real per capita GDP. It seems to have shifted downwards in the post-COVID, since the start of COVID, yeah? Right, if you look at this trend line here, the pre-policy trend line, it seems to have continued on the same growth rate, but it's now at a lower level after COVID. Other provinces like Quebec seem to have shrugged it off. If you look at Quebec's real per capita GDP series, they had a blip, but they seem to have taken it in stride. Ontario, as well, they had a drop of roughly, several $1,000s per capita, maybe $4,000 or $5,000 per capita, but they seem to be recovering a bit better than some other provinces. Okay, moving on then to the mortality outcomes, which is sort of the last thing I look at in this descriptive analysis. What I did here is fit. So these are the weekly all-cause mortality series produced by Statistics Canada. If you look at the raw data, there's incredible week-over-week variation. So to smooth out the variation, what I did is I fit these median spline curves, which are basically local averages, well, local medians, I guess, to these data, and did that separately by sex, male and female, by province and by week. So if you look at the data, you'll note, for instance, from BC, two things, well, a whole bunch of things strike me. First of all, there's a large seasonal component to all-cause mortality. I think that may be caused by the seasonal influenza virus, although I'm certainly not an infectious disease expert, but it seems to peak in the winter. And the same data for Australia has this shifted by 6 months. So there's that, and then there's also the fact that males tend to have higher all-cause mortality rates than females. Again, males are a bit less prudent than I think females. We've seen that earlier in the vaccination uptake, and so that they may have higher mortality rates for that and other reasons, of course. We also see pretty minimal impacts of the COVID pandemic, which is the start of which is indicated by this vertical line. We see not too much action, do we, in the all-cause mortality series in Ontario and Quebec. There's no abrupt shift, is there? Compare that to the three of the Western provinces, Alberta, Saskatchewan, and Manitoba, where there is a bit more pronounced increases in all-cause mortality rates for both sexes, although perhaps a bit more pronounced for males. Now, we also see, like I mentioned earlier, large increases in the all-cause mortality rate in two of the Atlantic region provinces, New Brunswick and Newfoundland, after 2022, which is when the provinces reduced or eliminated most of these stringent or these particularly onerous social distancing policies like stay-at-home orders and stuff like that. So BC, again, a little different story. Females, there's a slight increase in the all-cause mortality rate, but you really see it in males. And the question is, to what extent is that COVID? And to what extent is that other factors? We'll talk about that in a second. So moving on, Statistics Canada helpfully has provided us with data on life expectancy at birth by sex, province, and year, spanning the year 2000 to 2022. What do we see? Well, what struck me here is, well, first of all, females tend to have longer life expectancy at birth than males. That's true in every province. But that aside, what we do see is particularly large pandemic era drops in life expectancy at birth in Alberta and Saskatchewan. These are the same provinces, by the way, you'll recall, that tended to be the most light, had the lightest touch when it came to imposing social distancing policies like stay-at-home orders and business closures and school closures. So causal effect, ask Alex and Mehdi, but there's some hints there, isn't there, that there was some mortality impact of the policy choices. BC, again, we see differences in life expectancy at birth. By sex, with females, yes, declining, but males had a much larger decline. Hard to really know what the counterfactual would be had we not had a pandemic. How do you how do you define the can you use the pre-policy trend in some way to form a counterfactual? Hard to know. But just eyeballing it, it looks to me like there was a pretty substantive drop in life expectancy. And I'm wondering now about opioids and how that entered the equation for British Columbia as a potential explanatory factor. And then moving on to the life expectancy at age 65, which reflects in each given year the contemporaneous age-specific mortality rates for those 65 and over, summarizes them into this life expectancy measure. We see, like I mentioned before, particularly large drops in Newfoundland and Saskatchewan. Yeah, but perhaps more pronounced in 2022. Like the biggest drops were in the biggest reduction, or was in the year after the year in which they reduced all the NPIs. Saskatchewan, again, we saw that earlier in the stringency index values. They kind of were unique in their light touch in the application of these NPIs, and we see particularly large drops in life expectancy for seniors. And amongst males in Alberta, we also see a marked drop in life expectancy among seniors. Keep in mind that seniors in that province had the lowest rates of primary vaccine uptake as well. So suggesting an avenue for further research into causal factors. I think that concludes the formal presentation. I'd be happy to open it up.
Well, thanks, Paul, for sharing with us these interesting data and observations. So there is evidence that the pandemic or the interventions may impact on health and economic outcomes, and they tend to vary between provinces. So now I would like to invite our panelists to join into the discussion to provide their feedbacks and insights on any of the findings. We have got Mehdi, Sharifa, and Alexander. And at the same time, I would like to invite our attendees to type in their questions, if there is any, using the Q&A feature. Now it's now open for discussion. So may I start with Mehdi? What do you think of the data?
Yeah, sure. So something I don't think you present on, Paul, but what you had in the draft you shared was basically, and I mean, you touch on that as well with life expectancies. You want to go beyond mortality from COVID, then, because this is what we did in our paper. We just focused on COVID mortality. We focused on like COVID cases, hospitalization due to COVID, ICU use due to COVID. But where you go here, which I think is at least as important, if not more, is what happens to health outcomes beyond COVID outcomes. And I that's like an important direction for me. One other thing I would like to invite you to provide comment is, on well, GDP, because you said it yourself, it's going to be very difficult to make any attribution saying, well, this is because the pandemic was there and, well, what happened to GDP? And we tried something in this vein. We looked at unemployment, and we had basically the same kind of story as you found. Things picked up quite quickly in Quebec. The unemployment rate just like switched back, like I think 2 quarters after the beginning of the pandemic. It went as it was before, so basically nothing happened. Ontario rebounded quite well, but Alberta was suffering, for unemployment. So I mean, any additional thoughts you want to share on that? I think that would be appreciated.
Yeah. One idea I developed in the paper that I did not speak about in this presentation was the relatively small drop in GDP in the Atlantic region, because you'll recall they had the lightest MPIs. They shut their borders pretty quickly after COVID started, and they had very low case count, as you recall from an earlier slide. So they were able to, I think, keep their their usual businesses open, keep the economy humming as before, and that I think is reflected in the GDP series, isn't it? We don't see a particularly large drop if you look at Nova Scotia, for instance, right? Smaller drop than in, say, Ontario, although it's arguable. I mean, it's I'd have to do the well, I did the analysis in the paper, and they had the smallest reductions in per capita real GDP. Now, Newfoundland, though, again, they're an oil producing province, and they're going to be affected by these oil price shocks, aren't they? As is Alberta, and you can see it here clearly. So I agree, it's difficult to attribute causal impacts of COVID on these things, on these GDP figures. But there's some suggestive evidence, I think, that the provinces which were able to keep the MPIs surgically applied, like the Atlantic region provinces, were able to, it seems, suffer lower drops in real per capita GDP during the COVID era.
Or maybe I can follow up on that point. For the Atlantic provinces, it seems that the largest increase in the COVID-related mortality occurred after the interventions, the public health interventions being lifted in early 2020. Do you think that the governments could have done things differently?
I don't know. You see, I'm not sure exactly the extent to which people were not naturally immunized. Like a large number of people, again, I'm not an infectious disease epidemiologist, but in provinces like Ontario and Quebec, I think you had a lot of natural immunity because a lot of people got COVID, so that they were somehow inoculated naturally when the MPIs were removed in early 2022. That may not have been the case as much in the Atlantic region, right? Because people may not have been exposed to the virus and they were sort of virus naive. I don't know. If that's the case, then you have to be careful how you use these restrictions, right? Like, because you really got to protect. Now, I don't have the age-specific mortality rates here, but you really do have to protect the people who are vulnerable in those situations. You can't let your guard down on people who are living in long-term care facilities, perhaps, or immunocompromised. You have to be very vigilant. So I'm not sure. I don't know the details of what happened. In the provinces that experienced huge increases in all-cause mortality, I'm not sure how they handled the protections or how they protected those populations, but that could be something to be examined more closely.
Thanks, Paul. You
Okay,
touched upon. I'm sorry, Mehdi, go ahead.
No, I wanted to add to that because this is an important part of the story and part of also what we found in our paper. I mean, how we interpret our finding the paper is not directly what we found, but what we were interested in looking at was the interaction between vaccination and non-pharmaceutical intervention, and thinking that they may reinforce each other, or they may actually play in opposite force. Let's say if you have like more vaccination and people stop respecting the restrictions, except when they have a very strict one, they can stop, just like say, oh, you have to, school closure, there's nothing they can do about it, but just like stay at home, they can still get out. No. So that's what essentially what we're looking at. And what was a somewhat surprising finding is that, especially in the primary vaccine, we saw that the two actually work together. So independently, stringency, like reduced mortality, more vaccine reduce mortality, but in the primary part, especially for the first vaccine, it actually, we saw an uptick when you have like an interaction of the two. So that's, and we were trying to interpret it as, okay, maybe people are stopping respecting the restrictions. But for the secondary, I mean, for a booster series, this is where I think that's what your comments, Paul, were reminding me of. This is actually working. So when you, in the booster series, you see a negative interaction in the sense that having more boosters, when you have more restrictive policy, reduce the growth case rate, reduce the hospitalization, reduce the ICU utilization. And this is, and that's also something I think you show, Paul. This is because the booster was primarily taken by people who are more vulnerable, like older population. So that's how we are trying to make sense of it. And this is about like using surgically, as you said, Paul, like using like wisely the interaction. And if you want to, sorry, the policy restrictions, if you want to protect your older population or your more fragile population, seems like the way to go. But then it's just like, there's a lot of other debate about, you know, intergenerational equity. That's, I think, for a separate forum. But this is like, you showed, Paul, that, you know, in provinces where they had not much, and they said, okay, the concern is over. We have a like huge uptick of mortality, and this province tend to be also older provinces. But I think the story, like, you know, are kind of like going in the same directions.
Yeah, no, I'll have to review your results a bit more closely, Mehdi, and I think if I was to publish the stuff, I'd have to be able to tell a story about causal impacts. I think your results would be very helpful, and the direction you went, I think, is very fruitful in people getting immunized who are then less likely to, or maybe less likely to follow their social restrictions. And if the vaccine does not prevent transmission, if it merely prevents the person who's vaccinated from getting sick or very sick, then yeah, your story makes sense.
Just to build on that too, around the time the vaccine was implemented, the long-term care home deaths, at least in Ontario, went from almost 2,000 in the second wave just to about 60 and 45. So that's combined with some other long-term care home policies like the military going in, et cetera. But it went down all the way to 60 from around 2,000, and then picked back up after the restrictions were eased a little bit. So the vaccine definitely was effective from the long-term care perspective, and the relaxation of the policies definitely increased deaths after that.
And you tracked in your data, in your analysis, Alex, the long-term deaths by province. Is that?
That's the paper I'm currently working
on. Okay.
Just in Ontario.
I see. Cool.
I would like to add to this that there are two things. The first of all is that the vaccines were designed primarily to prevent the severe outcomes, hospitalization and death. And we have also seen in our vaccine effectiveness studies that we have done several during the course of the pandemic, that the vaccines protected better generally against the severe outcomes than the symptomatic infections or the infections. So that's one of the points, even if the vaccine uptake, particularly for the primary series, was higher, above 80 mostly, but that didn't actually prevent or protect against symptomatic infection or infection to the level that it protected against the severe outcomes. The other point I'd like to bring up is that we have seen that there were higher mortalities during 2022, right? But then there was a shift in the circulating lineage and sublineage, the variants. Omicron became circulating at the end of November, I believe, particularly in Ontario. And we have seen that even during the Omicron period, there were subsequent subvariants that emerged. First, there was B1, B2, then B4, B5, and then at the later part, after June, it was BQ and XBB variants, subvariants. And Omicron happened to be more transmissible and also immune invasive, particularly the B4, B5, and BQ, XBB. In our vaccine effectiveness studies.
Sorry,
yes?
I just quite missed what you said in the last sentence. Can you repeat that, please?
So I'm saying that particularly the B4, B5 variant, subvariant, and the BQ, XBB, those were more immune evasive. So they were more, able to invade person's immunity, even if they were infected or even they had vaccines.
Oh.
And in our study, where we looked at the effectiveness, particularly during the Omicron periods from January 2022 until the end of June 2023, one of the things we found that even the vaccine effectiveness against severe outcomes of the 2 doses of the primary series, vaccination series, alone, like without any prior infection, okay, was generally quite low, below even 50%. And also particularly during the BQ and XBB period, and also they waned quickly. So that definitely also played a part, the circulating strains, subvariants, the vaccine effectiveness, and you have also shown that the booster uptake also became low, right?
Right.
We did see that with the booster uptake, there was a transient, spike in the immunity protection, but also it waned quickly, particularly for the XBB, BQ and XBB period. Like the more immune invasive the Omicron became, the immunity also decreased quickly. We also took a look at whether hybrid immunity, that is protection from both vaccine and from infection, prior infection, whether that elicited a longer lasting immunity. But then again, none of those provided long lasting immunity. So ultimately, during the time period that we followed up individuals, like up to a maximum of 15 months from the last immunogenic exposure, we did see that it declined even with the hybrid immunity. So I think it's difficult to tease out, individual factors that led to the mortality or increased mortality, because so many things come into play during the pandemic and also after the pandemic.
Yeah, that's very helpful, Sharifa. Thank you for that. I wasn't aware of the particularly virulent or I guess immunity invading aspect of the Omicron variant and its subvariants. That in itself could explain, in addition to any changes in MPI policy, the massive uptake we saw in COVID attributable mortality in late 2022.
I can see 2 questions in the Q&A sections. Are you able to see those, Paul
Yep.
and Mehdi? Yeah. So maybe I just read them out. The first question is, when you examine change in GDP, did you look at absolute drop or percentage drop? If absolute, might it be that the province started at a low level to account for the smaller drop? Coming from Nova Scotia, I can say that in addition to our bubble, we had provincial stay-at-home order for months, apart from essential services. Who would like to take that question?
Well, I'll take the second question first. That is interesting. Thank you for the Nova Scotia information about Nova Scotia's MPIs. Like, if you look at this data here, taken directly from this Canadianization of the provincialization of the Oxford Stringency Index, if you look at their data, they suggest in Nova Scotia there was only a short stay-at-home order, yeah, but the questioner, the person asking the question suggests it was longer. I'm sorry, I missed that.
Sorry, it's just a noise. Sorry.
Okay. So that suggests that I'd have to re-examine the accuracy of this IRPP Oxford stringency data. It seems to be incorrect for Nova Scotia at least. And the first question about the percentage versus absolute, I didn't actually look at percentage drops. I looked at absolute drops in my paper. I guess, would you expect a larger absolute drop in provinces where the baseline is higher? I'm not sure, actually, offhand. I don't know which way that would run. I can't see reasons why there would be on a per capita basis, real per capita basis, why there would be a larger percentage drop in provinces with higher baseline levels of economic activity, but.
Right, thanks, Paul. The second question is from James. I think it is possible that people who took the primary series may have seen it as license to take less care in terms of other NPIs. So it's possible that there was, so with boosters, a few people got boosters and that cohort continues to do so, is more likely to be more vigilant in other ways as well. So any comments on that?
So I think it relates to our paper, and that's where we hit the limits of the data, because the data, there are provincial level observations, so we don't get to get micro data to look into more like other preferences, just like other risk preferences. But I think you had a good point. You're raising a good point that saying that booster, it's not only about the effect of the booster, it's also about the type of people who are likely to take a booster, who may also be, well, more risk averse, more prudent, take more care. And this is also why the kind of interaction of booster is not only reflecting the fact that people are protected, somewhat by the booster, but also by the fact that there are certain type of people who will be more prudent in general. So thanks, that's a good point as well. And perhaps on the first one, sorry, Alex, on the first point for Paul, there is also the Bank of Canada Stringency Index. So this is the one we used. But I don't recall that they published the sub-indices. I recall we use their main one, so the combined, but there are sub-indices that may be out there. So if you are not so sure about the other index that you use, might be another avenue. And sorry, Alex, please go ahead.
Well, I just wanted to build on some context to the last point. In our analysis, we did it before the vaccine became readily available, with just the intention of focusing on the non-pharmaceutical interventions. And we found that it had already started, that people were being less and less compliant as the days moved on, as the weeks moved on after the implementation of the policies. So we were seeing significant drops on compliance following like 3 weeks after the policies compared to the first couple of weeks. So it's likely that was already a trend before the vaccines, and then after the vaccines, it could have been intensified too.
Interesting point. And that your measure of compliance, was that the Google Mobility Index data?
Yeah, the Google Mobility reports, yeah.
Any other comments? Thoughts? Well, maybe I would take the liberty to ask the last question in this webinar. So just imagine that we are going to have another pandemic, who knows when, but hopefully not too soon. For example, an avian influenza pandemic. How likely do you think people will respond to non-pharmaceutical interventions and to receive their vaccines? Questions to both our speaker and our panelists.
Well,
I think it would likely depend on the severity in other countries, if it hits other countries first and then comes over. But based on attitudes, this would just be my complete guess, would be people would be less compliant. Historically, I've seen some hurricane data that if there was a false alarm, then the second one that was a real alarm would have less people less prepared, more deaths from that hurricane. So I could see the same thing happening with a pandemic, unless, of course, it was so severe in other countries first that there was no way around it.
No, I totally agree with Alexander. Yeah, I think that's also the human nature. I think people at this time have reached sort of fatigue, even for the vaccines and the NPIs, non-pharmaceutical interventions, even after the first wave of the pandemic. Like, people were not very much willing to follow those regulations. So unless and otherwise, it's very severe form of pandemic or whatever disease comes into play, and people are, feel the threat of being themselves affected, it's unlikely. It's just by human nature. And yeah, but we'll have to see how things go if we get to see another pandemic of this magnitude in future.
And if I may, because I want to be sure Paul has the last word, I would actually, I would even question the likelihood that NPIs are implemented again, because we've been seeing, later in the pandemic, how there was a reluctance to just ask people to wear masks, just something as less constraining as stay at home. I mean, we have a paper that we recently published on politics and restrictions, and we are looking at Italy and Spain. And I think what was really striking in regional election, what we found is that, contrary to what other countries like the US found, is that politicians, to stay in power, to increase their chance of being re-elected, they actually used more stringent policy. And the way while in the US, it was the other way around. If they wanted to have a chance to be re-elected, they were actually using less stringent policy. So, and what we didn't compare US, Spain, Italy, but I think if we try to make sense of what it says, in a way it says that, and remember, early in the first wave has been completely catastrophic in Spain and in Italy. There has been a lot of deaths. So in the context where the threat is seen as existential, the restrictions are going to be, essentially implemented. While in another context where we said, it's a privation of freedom and liberty, just less going to be implemented. So it's not. So I think this is the first step. Are we even going to see NPIs? And then if we have NPIs, what are we likely to see? And all of that is educated guess. Okay, I didn't do any. That's not what my research is saying. And that's it. Thanks.
Well, I guess I get the last word. Thank you. My understanding is the flu, the H1N5 or H1N1 virus is completely different in its etiology compared to the SARS-CoV-2. I think it's a bit more lethal, this bird flu. If it is, that would change, obviously, people's calculations about the value of keeping a low profile, staying away from others, avoiding infection on their own. Another complicating factor is the uptake of the vaccines. There's been a lot of blowback in the States, particularly in respect of the safety of the mRNA vaccines, and a paper that came out quite recently suggested that the risk of serious adverse event, as defined by this Brighton collaboration, I'm not know too much about it, but the claim they are making in this paper, based on the reanalysis of the trial data from the mRNA vaccines produced by Moderna and Pfizer, or Moderna and some other companies.
Paul, because of the interest of time, I think that we will need to defer this discussion on vaccines on another occasion. I'd like to thank you for your great presentation, sharing with us the data, and all the panelists in the very insightful comments and discussions. And I'd like to thank all who joined this webinar, and I hope that we will see you again soon in one of our activities organized by the Institute for Pandemics. I'd like to draw this webinar to a close. Thank you very much. Thank you.
Okay, thank you.